How about on the lateral side? Just the lines of flexion condyle as well?
Yes, I take lateral, medial condyle and epicondyle together, cut it, shift it proximally and fix it with the screw.
Type 3 valgus deformity where the medial soft tissue is expressed and you leave the radial structures, so there is a large amount of gap which will be there.
Yes.
And the larger poly would be required even if you take minimum TDO.
Yes.
So would it not lead to elevation of the joint line and would a TC3 implant with a smaller poly get better?
Right. Definitely, there would be a difference in the joint line, but in a biological engineering, slight elevation of the joint line may cause patella baja or a patellofemoral articulation problem, but overall, in long-term results, it matches and the soft tissue gets adjusted to that.
One more question.
Yes.
After balancing, you still feel the shoulder side is opening too much. But when would you go for a constrained implant and when would you remain with it?
Yes. Instead of going to constrained implant, if the medial collateral ligament is having longer distance, I rather will like to do
Lateral side is opening up too much.
lateral. Say again.
After doing the releases,
Yeah.
the lateral side is opening too much.
Lateral side cannot open too much, because in valgus knee, the lateral side is contracted and we will go on elongating till it becomes equal to medial side. Thank you.
Thank you very much.
Thank you.
We're now going to move on. I'd like to introduce Dr. Gupta of the United Kingdom.
Thank you very much, Lawrence. Thank you, Dr. Sancheti. I'm going to talk about management of bone loss and revision total knee arthroplasty. Over the next 10 minutes, we'll discuss about the etiology of bone loss, the classification, principles of management, discussion of few results, and I'll drop a logarithm for treatment. So what's the etiology of bone loss? It could be due to debris generated by osteolysis, could be by infection, problems moving implants or revision, a resection of the primary implantation, stress shielding, or collapse due to overload. The defects are often central. Defects are often central, have osteoporotic margins, and a typical ice cream cone. We tend to classify bone defects according to the Anderson Orthopedic Research Institute Bone Defect Classification System. Type 1 has intact metaphyseal bone with a near normal joint line. Type 2 has a damaged metaphyseal bone, which could be either A or B, depending on which condyle it involves or whether it involves both. This normally requires cement, cancellous bone graft, or augments to restore the joint line. Type 3 is the one which has a deficient metaphyseal bone that compromises major portion of either condyle. And this normally requires either a structural bone graft or a hinged or custom implant. Now this is the pictures of femoral defects. F1 has intact metaphyseal bone. F2, which could be A or B, has damaged metaphyseal bone. And type 3 has a deficient metaphyseal segment. The same applies for tibial defects, which could be T1 if it's intact metaphyseal bone, or T2 if it's damaged, and T3 has a deficient metaphyseal segment of sleeve. The aims of surgical procedure in a revision knee arthroplasty are to obtain a stable fixation of the processes to host bone, to restore pre-arthroplasty height of the joint line, to correct alignment, to have minimal bone removal, to obtain a stable range of movement, and to achieve all these goals with the least degree of constraint so the soft tissues can take the load during load transfer. So what are the considerations while doing a revision total knee arthroplasty? Age of the patient, activity of the patient. I think it's important to know the bone quality, whether it's osteoporotic or good quality, the soft tissue envelope around the knee, and of course we need to do a thorough preoperative planning. The operative techniques will include either cement filling, we could either lower the tibial section, translate the component away from the defect, or downsize the femoral component or tibial component, use modular revision knee systems, use augments or wedges, and we'll come on to the indications, use custom implants in certain severe cases, or in bone grafting. We tend to use cement filling because it's simple, it's cheap, it's quick, but the defect has to be less than 10 millimeters in depth. Less than 50% of the tibial plateau should be involved, or the femoral conda should be involved. Therefore, it's indicated in only small peripheral defects. The disadvantages, we all know, are poor load transfer, risk of femoral necrosis, risk of cement shrinkage at polymerization, inability to resist shear stresses, and creep. Now, this is an X-ray of a patient who had a total knee replacement, has osteolysis both on the femur and tibia. We use a long stem along with cement. We could even use lower tibial resection, normally done for defects less than 2 centimeters. We know the tibia becomes significantly weaker beyond 1 centimeter. The resection must be above the Curtis tubercle to protect the iliotibial band, which is a normal and important lateral stabilizer of the knee. We should protect the lateral and the medial collateral ligament insertion, which is normally about 2.5 centimeter distal to the joint line on the tibia and femur. It's only appropriate when the bone loss is almost entirely tibial and the patient has patella alta. The drawback is it tends to raise the right joint line. Now, this is a diagrammatic representation of a tibial bone loss. I think it's wrong to do a resection right up to that level. Idea is to take a resection halfway and then build it up with augments on this side. We could also do translation or downsizing of the components. This tends to reduce the area of contact and therefore decrease the load distribution. This is normally done for small peripheral defects and restricted by post or stem abutting cortices. It's only appropriate in primary TKR or small defects. As I mentioned before, we could use augments. The advantages are to allow the implant to be supported directly by the host bone. They provide good compressive forces on distal bone. There's no risk of osteonecrosis collapse as you have with the bone graft, and they're readily available and relatively straightforward. However, the disadvantages are the blocks may necessitate removal of cortical bone or intact bone to fit them in. Blocks more than 1 centimeter should have a stem, as I'll show later, and it's possible that there is third body generator body wear from fretting between the screw, tray, or augment. And of course, they're more expensive than a bone graft. Now, these are the augments used for restoration of the joint line after any significant bone loss in either, this is the femur, and this is the picture with us interpretively. We use augments to raise the distal femur and approach the joint line. We will also use wedges. They of course allow less bone resection because of the structure. They increase the shear stresses and they reduce the loading of the distal bone. But they must also always be used with a stem. So coming on to the stem, we can use the cemented stems which provide enhanced fixation compared to no stem. They're easy to revise. They provide less stress shielding proximally than cemented stems. However, the disadvantage is that the position of the stem normally dictates the position of the tibial tray unless we have an inbuilt or a dialed in stem. There is always a risk of tip pain or fractures around the tip. This is a picture of a patient in which we used a tibial tray with a stem, uncemented. Coming on to the cemented stems, they improve fixation in osteopenic metaphyseal bone. We know from studies that a 70 centimeter stem can offload the proximal tibia by almost 25%. They improve tibial tray positioning and can be desirable for rotating hinge. Of course, they're most difficult to remove because of cement integration. We can also use bone grafting. Autografts, of course, available in primary TKRs, could be harvested and stored. They store the host bone stock. They have high rates of incorporation demonstrated with bone grafts. They can be fashioned to the size of the defect, and they tend to have physiological load transfer. There are a lot of studies to show success in bone grafting. They tend to create a relieving bed on the host bone, and they tend to fit accurately without taking more bone off, unlike an augment. They tend to completely cover the graft with the component, and they protect the graft. We should protect the graft with the stem. You can also use impaction bone grafting in certain cases rather than cortical bone. This is a picture where we use impaction bone grafting. This is a radiograph of the impaction bone grafting with a mesh. We can also use bone allograft, more commonly used in Canada, where I did my fellowship. There are various studies and publications. Gross publishes 100% success in 2008, which was also covered with Leo Whiteside in 1993. Of course, the latest metal workaround is tubercular metal revision knee systems. We can use a cone as shown here. So tubercular metal is normally a porous metal which has a porosity which mimics the cancellous bone and allows bone ingrowth. It could come in various sizes and forms, could have a tubercle metal cone for tibia, could have femoral cones, could have metal augments for patella, or augments for both femur and tibia. Now this is a picture of a revisionary system which has a typical cone defect. We filled that up with a tubercular metal augment, the same augment with the side picture. There's another sizing device and the augment. So tubercular metal augments, I think, are the new things in revision knee arthroplasty systems. They tend to have compressive load forces around the bone. They could come in various angles, normally a 14 degrees medial lateral angles, and have a 12-degree posterior slope for clearance of the cortical wall. Another radiograph of the using of cones for tibia. So what's the algorithm for reconstruction? Well, if it's a type 1 tibia or femoral defect, which is small defects, I tend to use a PS component with cement. Use stem if there's poor bone quality or osteopenia. For a type 2 femoral tibia, I tend to use an augment or a stem. Use cement if it's less than 10 millimeters. Graft in young patients, of course, tubercular metal to bail us out. If it's a type 3, I use a rotating hinge knee. Thank you very much.
Next speaker is Dr. Patellar, who's going to select taking the arthroplasty extra-articular
नहीं है तो आए नहीं आपको देखिए अच्छा उधर आए चलो कोई नहीं just open it. Good afternoon, ladies and gentlemen. Mr. Chairman, I had given the talk there but somehow did not reach here. I would like to thank Dr. Maria for inviting me for the lecture. And the title of the talk given was Modern Designs in TKR, Do They Make a Difference? With a special reference to extra-articular deformity. Well, they try to combine the two talks. There is no design made with special reference to extra-articular deformity. So we'll be talking about the modern designs in TKR, do they make a difference? These are my disclosures. Every company is trying to build up new designs. There are a lot of companies in the world who are trying to come up with their ideas and their designs, but do they actually make a difference? Even the 6 big companies, they keep on changing their design after every 8-10 years. As soon as we get the long-term results for the previous implant, they come with a new idea in the market and design new things. Now we have this knee from DePuy, Attune knee. They have certain features added which they thought would make a difference. They have reshaped their trochlear groove. They have tried to do a G radius, so-called gradius, so that gradually the radius of curvature on the male condyle reduces. And they have changed a little bit in the contact area and locking system in the tibial plate. Similarly, Zimmer's come up with their new implant again, and called Persona. Again, they have made a little bit of differences in the design. They've changed the tibial plate design. They've reproduced the ligament balance, so-called, by increasing the inserts in 1 mm bits rather than 2 mm bits. And on the femoral side, also they tried to make 2 mm increments. So this has increased the paraphernalia, the implant size is available, but has it actually made any difference? Again, Stryker, they have come up with their own design with a medial single radius one. So all the companies are trying to do these things. And in the last sort of 10 to 15 years, we have seen emergence of a lot of new features trying to claim that they will do this and that, but has it actually proven the test of the time? We have had gender-specific knee now, which is not actually just gender-specific. It's difference in the sizes on the medial, lateral, and the AP dimensions. Some of the males fit the female gender knee. Some of the females fit the male gender knee. So it no longer remains a gender knee. It's a mixed knee now. The high flexion TK, it started with a bang. Yes, we're going to get big, deep flexions, and everybody will be able to sit crouching. But has it stood the test of the time? Not many studies show it has. The only difference is it has made, and some studies say it's just about 3 degrees more of flexion, which is not really a great high flexion. Cementless TKA, people have designed. They're still going on a little bit, but only about 2 to 3% of cases they are being done. Then we have medial pivot knee. Has it shown any great difference from the previous ones? No. Mobile bearing knee, has it shown any great difference from the fixed bearing knee? No. Carbon impregnated polythene. So all these industry maneuvers to try to get things right don't seem to be working. Because the factors that lead to successful total knee replacement is not just the design. It's a proper patient selection, and most of it is correct surgical technique, which is based on us, not on the industry. And effective perioperative care, yes, you should select an appropriate implant. It doesn't necessarily have to have all the cutting edge features which are come just yesterday in the new implant. So let's look at why and when the knees fail. There's this paper from Sharkey et al., which looked at 212 revisions. The average time to failure was 3.7 years, and 55% of them failed within 2 years. And the reasons were basically instability, implant loosening, stiffness, malalignment, all the surgical factors. 70% of the failures within 2 years, less than 2 years, were related to the surgical technique. Another paper in the Knee Society that was presented in 2012 in US, 61% failed within 5 years, and in a single institution one, 46% failed within 5 years. So all these early revisions happen. The strategies to improve this outcome should be aimed at initially infection prophylaxis, because that's one of the major reasons for revision, and surgical techniques. That's the other cause for early failures. So are all these 3 designs and other designs, they are not directly addressing this issue of solving the initial part of the failure of the knee replacements. Let's look at the late failures, more than 5 years. So late failures are also a major group. Again, they are not directly addressing the issue because late years are mainly related to loosening and wear. Loosening and wear, these are problems which can be solved perhaps in a well-aligned, well-balanced knee, rather than just by the design of the knee. So what are the problems with the current total knees? We looked at this paper which shows correlation between the commonly used clinical outcome scales and patient satisfaction. The two show that they are not related to the knee designs. The patient satisfaction, what design implant features can improve these clinical outcomes that will improve the patient satisfaction? Is it based on the implant design? No. There was this paper which received John Insall Award, which correlated the satisfaction with different factors. And the only factors they came up with, it was slightly related to the age and the absence of residual symptoms, mainly pain, and absence of functional impairment, that the patient was able to perform his routine daily activities, and also fulfillment of expectations. So in the 2 groups that were satisfied and dissatisfied, they looked at, there was no difference in the number of activities actually performed by the 2 groups, but they were still unsatisfied or dissatisfied groups. The dissatisfied ones had more difficulty in performing the activities of daily living. The dissatisfied ones experienced more difficulty and functional deficits in performing the functional activities of greatest personal importance to them. So satisfaction is primarily determined by expectations rather than absolute level of function or by the design of the implant. So what implant design features can improve your clinical outcomes and patient satisfaction? All you need to have is absence of functional impairment, fulfill their expectations, and no residual symptoms of pain, especially in the high demand patients. So does greater knee flexion increase the patient function? Yes, it does, but look at how much. Flexion above 130 degrees will increase their satisfaction, not before that. And no implant design can achieve just by itself producing 130 degrees of flexion. The TK must allow performance of the desired function for the patient to be satisfied, and pain relief is one of the very desirable things in that. So are these cutting edge designs trying to solve this? No. Are they allowing the safe flexion of beyond 130 degrees, the durable demanding activities, and being pain free without affecting their longevity and current results? None of the designs does that. Another study, very interesting study by Doug Dennis and a lot of other people from different centers. They compared the new Persona knee along with the next gen gender high flex knee, which was the previous knee, and in the same patients they asked, a third party actually asked, not the surgeons themselves, that which knee felt better. And when interviewed by this independent third party, the patients with modern TKAs reported more residual symptoms and less satisfaction than those with traditional knees. So what things are we solving by making little changes in the implant designs? Again, I would say the factors leading to successful total knee replacement are you manage the patient expectations and do a correct surgical technique. Any appropriate implant design would give you kind of similar results. Thank you. I would like to invite you to the Chaos International meeting in Italy in 2014 June, if you're interested. Thank you.
Do you have any questions, please? Okay, thank you very much for your talk.
Thank you.
I think our next speaker is going to be Sudhir Garg from Flexion Tk.
Thank you, Mr. Chairman, and good afternoon, everyone. Few of the points of my topic has already been covered by Dr. Kamaldeep, so I will try. He has already said that it doesn't work, so I have to prove that whether it works or not. So that's what I'm trying to do. So we all know that range of motion, especially flexion, is the most important factor which determines whether the knee replacement has been successful or not, especially in our setup. But when flexion up to 110 degrees enough to allow almost all activities of daily living, then why we need a deep flexion implant which gives us more knee replacement or more flexion? Because there are cultural and religious activities which we perform, which require squatting, kneeling, and cross-leg sitting. And in some cases, you may require flexion up to 165 degrees. But there are many factors, not only the implant, which affects the post-operative flexion, which may be patient-related, such as high BMI or previous surgery, or maybe technique-related, as Dr. Kamaldeep has already said. There may be component malpositioning, there may be overstuffing of the pattern of femoral joint, or there may be failure to remove posterior osteophytes. They all affect what post-operative flexion we are going to get. But the single most important factor, as mentioned in various published studies, and this is also our experience, the post-operative flexion will depend on the preoperative flexion. Patients who have higher preoperative flexion will get higher postoperative flexion, not the vice versa. And thus, implant design, especially these high flexion TK, they do contribute in achieving that. That's what I'm trying to answer. There are two major mechanical factors which affect postoperative flexion. They are the femoral rollback and the tibial slope. And the various designs modification, they are centered around improving these two factors. Some implants, they have reduced radius of the posterior femoral condyle, which improves the articular contact area at high flexion and also improves the femoral rollback, which in turn improves the range of flexion. Similarly, the femoral cam has been shifted posteriorly to increase the jump distance and to improve the stability in deep flexion. In tibial component, tibial post has been shifted slightly posterior, and similarly the posterior part of the tibial insert has been recessed to relax the posterior slope, which opens up the flexion gap, and both these factors in turn facilitate the femoral rollback and then facilitate the range of flexion. Another change which has been done is the anterior part of the tibial insert has been recessed to reduce the patellar impingement during deep flexion, and which in turn help in improving the flexion. But there are some issues with this high flex TKR. There are issues of increased wear, there are issues of instability, and obviously the big question is whether they do help in improving the flexion. Shortening the posterior radius, it results in increased contact stress, not on the tibial insert surface but also on the cam. So there is potentially greater risk of wear and early failure of these inserts. There is also some concern with the cam post instability, but that has been largely addressed by shifting the cam slightly posterior, which increases the jump distance and thus reduces the chances of dislocation. But the main question is, does it improve the flexion? If we look at the literature, yes, it does improve the flexion as compared to the standard group. If we compare the published literature, it tells that there is slightly more flexion where the high flex implant was used as compared to the standard, and more of these patients where high flex knee was used were able to squat as compared to the patient where a standard knee implant was used. And significantly, patients with severe preoperative flexion limitation achieved more postoperative gain in flexion when a high flexion prosthesis was used. So there is some advantage over a standard knee as far as the published literature is concerned. But as far as functional outcome is concerned, there is insufficient evidence whether it helps in improving the function. It does help, probably help in improving the flexion, but whether that translates into a functional improvement, that's a matter of debate. So we are doing this. So this is small study, total of 104 patients, average age was 62 years, average BMI was 30, bilateral TKR in 81, unilateral in 22, and in all of these patients we used posterior substituting implant. There was significant fixed flexion deformity in more than 50% patients, and you can see that significant, more than 60% of these patients, they have mean range of motion ranging between 70 to 90 degree. And if you look at the postoperative range of movement, the significant number of patients, more than 70% patient, they have a postoperative range more than 110 degree. So average gain in range of movement was approximately 28 degree, and patients who had lesser preoperative range of movement, they gained more as compared to the patient who had higher degree of movement before surgery. There was significant improvement in knee society knee score, which improved to 86, and function knee score, which improved to 75. And surprisingly, the patient with bilateral TKR, they had better post-operative functional knee score as compared to the patient who had unilateral TK. Total knee replacement. This is probably due to the existing osteoarthritis in the other knee, which compromised their functional score. So there was no comparison group in this study, but the results were similar. If you just look at this table, the mean range of flexion which we gained is 114 degree, which is less as compared to the other studies. But if you compare the preoperative range of movement, in our patient the preoperative range of movement was also significantly less as compared to the other studies, but the mean gain in range of movement with high flex knee was almost equal or better than the other studies, and if you compare to the standard group, it was much higher. So to conclude, their current evidence does suggest that there is some difference in the flexion gained by using a high flexion TK, but whether it translates into functional improvement is a matter of debate. Thank you.
Thank you very much. Do we have any questions, please? Dr. Garth. Thank you very much.
Thanks.
Sorry, whoops. Sorry.
One question is there for you.
I apologize.
No.
High flexion is supposed to cause more stress across the joint and supposed to treat the osteoarthritis in individuals who are using high flexion activities.
Okay.
And after TK, we are advising, we are doing high flexion TK and advising patients to continue the same high flexion activities. And so the impact is supposed to play the
If as far as my practice is concerned, we do high flex TKR in majority of patients because of two reasons. One is the function demand of the patient, and the second is because we have seen that where we have used the high flex knee, they gain movements slightly quickly earlier than patient where a standard knee was used. But we tell our patient not to squat and not to sit cross-legged. Though we have put in a high flexion knee, but that's only for if it is really needed, not regularly. Yes.
So do you find a difference in longevity, the survival of implants?
Sorry?
Longer survival of implants?
Yeah.
In a high flexion knee versus a routine standard knee?
Literature doesn't say there is a lot of difference because some modifications have been changed, though there are concerns, but I would still go for high flex knee.
And all the major studies have shown preoperative range of motion is the single most important factor that contributes to the postoperative range of motion.
Yes.
So when you say that the patients who have lesser preoperative range of motion benefited more,
Yes.
you mean to say that preoperative range of motion was 20 or 30 and he gained 90 or 110, that's significant increase. And a patient with preoperative range of motion like already 90 or 110 gained only about 120, that's not a significant increase.
Yes, that no. Both patients they gained, but the gain was less in patient who already have a very good range of movement. It's a relative term. The patient who had lesser range of movement, they gained more. Like patient who had only, like he had a 30 degree of fixed flexion and 90 degree of flexion, 80 degree, he has only 50 degree of range of movements. But that patient has gained more. It has become from 0 to 90 degree or probably 0 to 100 degree or 110 degrees. So the gain is much more in patients. Because we are not talking of the absolute range, we are talking of the mean range from a deformity to the final end point. So we are talking of mean range. So that's what I'm saying. If the mean range is less, its patients are going to get more benefit.
And when you say high flex knee, with good proper surgical technique and better patient selection and using the appropriate implants,
Yes.
even high flexion can be achieved with the normal standard TK, standard knee implants.
If patient have good preoperative range of movement, I think patient they achieve good range of movement postoperatively even with standard implant. But probably there are issues with standard implant in deep flexion. But though they will remain, but otherwise they also achieve good range of movements. There is no harm in using patients who doesn't want to squat, doesn't want to sit cross-legged to do a standard knee. I won't disagree with you on that one. Thank you.
That draws to a conclusion, this section. Do you want to say something?
Oh, is there another one? My talk is after this.
So I didn't know.
I do apologise. I not see it on here.
On Saturdays, I think.
Did they move it?
They moved out to. Was it?
It's a 3:45. It's the last talk anyway.
You're very welcome to talk. I do apologise. So I seem to have an error on my programme here, but I'd like to welcome Mr. Mahapatra from Ireland, who's going to speak to us about the rotating platform LCS knee.
That's all right. Thanks, Mr. Friedman. Thank you, Mr. Friedman, and I'd like to thank the chairpersons, Mr. Sanchetti, and all the senior delegates, and also like to thank IOA for inviting me down to this place. All the things have been transferred from one place to the other place and all that. I don't know how much of slides will come through, how many of videos will work. Please do excuse me if it doesn't work. It's actually a world on a rotating platform. This was initially when I was contacted, I was asked to debate against an Indian colleague about rotating and a fixed platform, but then there was changes and there were further changes, and then this talk was put into this section. So it's most, please feel free to ask me any number of questions on rotating platform if you're a fixed platform guy, okay? So going on to the history of the LCS, we had the first LCS implantation way back in September 1997, and it was called the New Jersey knee. It was, of course, we have heard ad nauseum about the contact stress, and my previous Dr. Garg also talked about the contact stress and how to reduce the contact stress and how does it affect the implant. The history goes on to after nearly 23 centers recruited in 1981, there's a FDA cementless approval in 1984 and a cementless approval in 1990. Now, FDA is the American one for it. So it's all from Buchel and Pappas' work. And it was actually Frederick Buchel, who was a consultant orthopedic surgeon, along with Professor of Engineering Michael Pappas. So they worked very closely and got this very well done design. They did make some further changes. Now, design objectives for a total knee is pain relief, natural movement, correction of deformity, revisability to reduce the component wear, and loosening and implant longevity. I think most of us who do knees start with probably femur or tibia, depending on what you're using, but LCS somehow has been sold as a tibial reference knee, and it's very important you balance this knee well so it works well, otherwise there's a spin out and there's a problem. So after that you have your balanced AP and femoral resection, you have a distal femoral cut, you have your gap check, and after, of course on gap check you have to be sure that you're using the correct amount of the width of the gap, because you tend to stretch out the collaterals if you try to put a bigger lollipop there, and that will give rise to a wrong gap check. And your finally your femoral finishing guide. Then we have your tibial finishing guides to finish off with this. Stress and congruency, these are two important things. Congruent, large contact area between femur and poly, and low contact stress and high constraint. But a flat, small contact area, high contact stress but low constraint. So these are two ways of looking at it. We have large contact area here. Again, if you look at it on that, and we talk about low contact stress then. What are the options? You could have any number of options: mobility with congruency, mobility without congruency, and then mobility with congruency. So one is without, one is without with mobility. So one is you have to either reduce something to get something more. So there is a balance in between these two. So congruency without mobility. Constant means a shear and a torsion force should be transmitted to the fixation interface and increase the risk of implant loosening. So this way, if you have this moving out there, so it doesn't pass on the stress from the poly to the tibial plate, and then it does dissipate any amount of stress that the tibial plate has between the tibial plate and the bone, with an interface of whether you're using cement or you're not using cement there. So in LCS congruency, the full congruent between the femoral and femoral component, the tibial and the patellar bearings, where I must say I don't do patellar resurfacing, I just don't do them. We can talk about that in some other meeting or later on, where weight bearing loads occur with most frequency. This tells us most about it. Of course, you do see guy is happy because the stress, or even if she is nutritionally a bit more well covered, but still then because the contact stress is so low. Hopefully this works here. So you can see this is a modular way of looking at it, and if you keep looking, oh sorry, this one is not working anyway. So when you walk in, how the contact stress is changing, and you know, during the heel strike, and then again during the toe-off phase. I wonder whether this will work again. And you look at the heel strike phase and then the toe-off phase, how it's coming to full contact in that place. So that's the way it's going on. It works here, it doesn't work there. Anyway, good. So why do most knees fail? So polyclean wear, there's abrasion, there's oxidation, there's a third body wear. There's a fatigue, pitting, cracking, delamination. The hips fail in a very different way than the knees. With the poly in the knees, failing in a very different way, we call it the subsurface delamination, rather than the hips, in which we have all the phagocytes and all the macrophages working on that. You can, again, showing delamination there. So reduced poly wear in LC is a highly polished tibial tray, reduces the backside wear, and then it goes to a high contact area. Congruency, even a varus valgus lift off. We did talk, I think Dr. Gerg's talk was very good on that. And if you have a huge amount of flexion you want to create, at the end of the flexion, you will see that the tibial plate tends to lift off a bit. And that's actually not right. When you get it on table and you see that, oh, it's trying to lift off when you're doing your trial, be very careful that this knee is not right. You're not doing the right thing. You will you'll put the implant with a bit of cement and you'll get out of it, but it is going to fail because it's going to still create that million cycle, gate cycle stress all throughout, and it's going to create more and more problems. So we do talk about strain hardening. Now this is a very good thing that has come up with in recent years when they looked at it. A complex knee movement decoupled to rolling between insert and the femur rotation between the back side of the poly and the tray. Then the polyethylene molecules tend to align over time with the movement, and the polyethylene is toughened. Now what happens is, as it tends to go in one direction, because it is not changing the direction, the femoral component, as soon as the femoral component tends to change, the rotating platform changes and the stress is in the same area of the poly, and that then hardens the poly and makes it better and better as time goes by. This is again something that showing that how the kinematics work. This is again showing on a fixed and a rotating platform how the kinematics would work, because it's rotating there. So it is always the same contact area and same hardening that happens. So unidirectional motion patterns hardens top and underside of the polyethylene, and it would reduce the wear by nearly 94%, which is pretty huge amount. Patellar friendly femur, well, we talk about the patella, the deep anatomic patellar sulcus at 130 degrees, and it's a natural patella angle is about 137. But a lot of people ask me that, how do you really think, because you open the knee and you find the patella is gone completely, so thin. How do you really replace that patella? How do you actually, and sometimes some of you say, oh, take 1/3 off, or take, I take 9 mils off. Somebody says, oh, I'm 11 mils, like this. It's not, because you cannot build up the patella unless you know what's a normal patella and the other side, if it's normal. Because if you're just replacing the patella because you just want to do a total knee with the patellar resurfacing, would you be overpacking the joint? Well, we go into LCS offers patients pain relief, mobility, reliability, and long-term survivorship and bone preservations. Or reliable and user-friendly. I've talked to many surgeons that they find LCS knees are pretty difficult to do. Technically, they are. Believe me, I started off with some knees, and then I went on, and now I do a huge number of knees in my unit, and I have seen that these are technically tough knees to start for a person who's starting these knees, but then over a period of time you would be able to do you know, once you've got the concept of this knee, you'll be able to get less and less problems and more better results. There are good clinical follow-ups on that. David Beverland from Northern Ireland, he's well known, he's done more than 3,000 knees, of course very less compared to what is done in India, as some of the surgeons have done huge amounts, but he's thought to be very good at this. Then there are a lot of studies from Korea and studies from America which shows the results of these knee at 10 years, 97, 98%. Now, please try to understand that a hip replacement, I don't say is easy, but the patient satisfaction is very good. But in a knee, 85, best of the best hands, 85 to 90% is the best you can get. You could get even 98 to 100% patient satisfaction in a hip replacement. I've run out of time. I'm sorry, Chairman. I'll have to stop. Yeah. Okay. Thanks.
Is this a knee you're recommending for us?
Sorry.
Is this a knee that you're recommending for the average?
Absolutely. Hands up. And I would say, had I had my chance to do it as a debate against any of the other colleagues, I would have definitely said, anything else they're doing is rubbish and this is the one. But as I'm not doing it as a debate, I would say give it a try. All those people, all my colleagues who I've met in since yesterday, and I've talked to them, if they want to try their hands at it, it'll be a good knee to try. But of course, there is a learning curve with everything. Please be sure that you know, get the right guy to take you through the first few ones, and then it should be easy. Because the spin-off is a big problem. You know, if you don't balance, it's rotating. It'll click and spin, and once it spins, it locks, and then you're in trouble. You cannot put it under general anesthetic, manipulate and get the spin back, because it's going to spin again. So you need to revise that, and it becomes a problem. A lot of people are afraid of that. Yeah.
Sorry I didn't have you on my schedule. I'm just going to draw this session to a close. Thank you very much.
Thank you, Mr. Friedman. Thank you, Mr. Sancheti. Thank you.